Hello, I'm Matthew Weinstock, Managing Editor for Modern Healthcare. Thanks for tuning in to the latest edition of the Checkup. As the coronavirus continues to surge in multiple states, we wanted to try to get a sense of what that might mean for encouraging patients to return to their providers for more routine, less emergent care, which we know is so important for them to do. But also take a look at how the surges may be impacting the industry's desire to move forward with some of the things it's been trying to do prior to the pandemic, including moving to more value-based care. I'm pleased today to welcome Dr. Penny Wheeler. She's CEO at Allina Health in Minneapolis, Minnesota, and Tom Lindquist, CEO of Allina Health-Aetna, which is a joint venture between those two organizations. Tom and Penny, thanks so much for being with us today.
Thank you.
Thank you, Matt.
So let's start on that topic of, before we dive into getting patients to come back for some routine care, give us a sense of where you are in Minnesota in terms of cases. You're one of the states that seems to be having a bit of a resurgence here. So Penny, can you talk a little bit about where the state is right now?
Sure. Yeah, we have had a higher number of case counts the past month or so, as high or higher than they were back in April or May. It's a little bit hard to compare apples to apples because of the number of testing has increased significantly. On the hospital side of things, we're actually seeing fewer hospitalizations than were there at our peak in late May. So there's a lower hospitalization rate, but we're seeing higher case counts, particularly true actually in our surrounding states. And so we're concerned about that raising even higher.
Yeah, obviously Wisconsin being one of those states that is really bubbling up over the past few weeks. So let's pivot a little bit. As you said, you're seeing lower hospitalizations, and obviously an area that the two of you deal with on different ends of the spectrum. Let's talk about trying to bring patients in for more routine care, whether it's the yearly exams they have to get, a physical or a mammography or something of that nature, or maybe even diabetes management. Can you talk from your two perspectives of how that process is going and what are you hearing from patients? Tom, let's start with you and what you're hearing from members, particularly maybe some of those seniors.
It's a really good question. I think the senior population is nervous and for good reason. And so, we've partnered with Dr. Wheeler and Allina Health to do some podcasts and some information to make sure people understand how important it is to get in for that care. But in addition to that, we're sending out convenience packages to our seniors that include thermometers and masks and hand sanitizers and all the things that they will need to help them feel safe. If a virtual visit is not for them, to get in and seek that care that they need.
And Penny, what about you? Are you, beyond the podcast you're partnering with, are there specific things you and your provider team are trying to do?
Yeah, well, first of all, Matthew, the concern is very real. We're seeing a 40% decrease in the number of people who are coming in for care with stroke. I don't think the stroke rate has gone down. And I'm hearing from colleagues, I heard from one just the other day that had a patient with 4 days of abdominal pain, didn't come in, and had a ruptured appendix. We're seeing complications that we didn't used to see before. I think to Tom's point, one is assuring that people can get safe care, can get care safely. Part of it's a fear of unknown. Some of these are first approach by telemedicine or something like that, and that's a new forum for many people. Part of it's a concern about safe practices and care, and are they at risk if they come in? And then I think another one that we worry about looming is some of the economic pressures on people, that they're actually with the economic challenges that we have related to the virus and beyond, that they'll avoid care because of concerns about payment. So we're trying to really work towards value-based payment and make things more affordable. But for all those reasons, we firmly believe that avoided care is not safe care. And that's a concern of all right now.
But if you're seeing that on the stroke front, which obviously is a very serious condition, how do you message to folks that, hey, you got to come in and get the proper care? I mean, that's pretty serious stuff.
Yeah, many organizations have been adaptive. Like many of us have gone, we went from 50 virtual visits a day to 4,000 to 5,000 a day during this. But I think what we're doing now is beyond that adaptation is being more proactive. So we're actually reaching out to people who had a scheduled cancer surgery but didn't come in for it, or who have a chronic illness and we want to make sure that, and is at risk for perhaps a stroke because of hypertension or something. So we're getting to the point where we were adaptive, and now we're being more proactive about reaching out to those people at greatest risk.
Interesting. Go ahead, Tom. I'm sorry.
We're doing the same thing. We have the benefit of partnering with Allina and having the not just the real-time data, but the claims data and the historical information. So we're doing the same and reaching out to these individuals that are at risk or emerging risk, and asking them to go in and see their physician, helping them schedule their appointment and get those visits.
So you both
that's the power of the partnership too, because we can't tell necessarily that a hypertensive patient hasn't filled their prescription. You know, when we partner with Allina Health-Aetna, we can tell whether that's happened. So it gives us a bigger risk profile about who we should reach out to.
And are you finding that those folks you're reaching out to then actually take action, or are they still slow to respond?
So from our perspective, when we reach out to them and help them make that appointment, we're seeing that they are in fact making them. Now, some of them are virtual, but they're at least getting that first foot in the door for the care that they need. Yeah.
So you both, Tom and Penny, have referenced telehealth. Obviously, it's exploded over the past 6-7 months here, with CMS lifting some of the restrictions on it, some of the payers starting to pay for it, although several are starting to dial that back now, which has some providers frustrated. Not necessarily on the payment front, but just thinking about the limitations of telehealth. What are they in terms of providing care, and how do we start to overcome them? And maybe Dr. Wheeler or Penny, I'll start with you. Where do you see some of the hurdles that telehealth hasn't been able to overcome yet?
Yeah, I think that a few. It's not all visits are virtual. So where you need intense physical exams, some extra lab work, some procedural work, that doesn't work. It works well for follow-up visits, medication management, kind of chronic disease management, lifestyle coaching, that. So the first thing I'd say is not all things are virtual. And then the other thing that we don't want to have happen is have, deepened disparities. There are some people who don't have access to broadband in some of our greater Minnesota areas, for example, or in some communities. So sometimes the platform itself, or access to the platform, is a barrier as well.
And Tom, what about for you? What about some of the members that you're dealing with that may have limitations on how they can access telehealth?
Yeah, that's so I'll echo Penny's comments. The access to broadband is a problem for some of our members and patients. I think the other side of that is the technical barriers that the payers and the providers are facing as well. So to Penny's point, there's been an explosion. And so as new solutions are coming in, we have to integrate those with our existing systems. And sometimes those systems are a little antiquated. And so, we're dealing with a little bit of a silver lining as it relates to COVID, because we've seen an explosion of innovation in healthcare, which is so overdue and much needed. With that comes the technical challenges behind the scenes of integrating all of this into the system so that you have that continuity of care and you don't have gaps where a potential issue is a member or patient calls in for a televisit, but it's not connected to anything. And so you potentially lose that continuity of care. So all of these are issues that we're working with our own systems and our partners to solve for as quickly as possible.
Yeah, interesting. And Tom, I don't want you to have to speak for the entire insurance market or for CMS, but I'm going to ask you to do that a little bit here. As I said earlier, some of the insurance companies are starting to dial back reimbursement for telehealth. CMS, although it has said it wants to make permanent the waivers, we don't know what that'll look like. Some of that may take congressional action. What do you think from a payer community? What response should it be going forward so post-pandemic we can keep some of the telehealth innovations alive?
So I think, first, thanks for the question. I think it's incredibly important that we don't go backwards. The steps we've made, especially with CMS and allowing some of these innovations to come into the Medicare space, are incredibly important. The reimbursements and the regulations, that's tricky. They always follow well behind the actual innovation. I think that's where the partnerships come in and value-based care, and where you work with your payer partner to develop a common set of goals, and the reimbursement can follow that.
Great. So let's dive into value-based care. Obviously, Penny, you have relationship with the Allina Health, Allina-Aetna partnership. You launched a couple others with the Blues plan, I believe, up there in Minnesota as well. How do you sustain that drive towards value-based reimbursement in the middle of a pandemic? We've been talking about telehealth, which isn't really necessarily a changing of value-based care. It's kind of shifting the patient from one place to another. But as you said, even on stroke, you're having patients not come in for stroke, so that's going to throw off, I imagine, some of your metrics that you may have in a value-based contract. So how do we sustain this going forward while you're in the middle of a pandemic?
Yeah, there is some noise definitely from the pandemic for people, for scheduled surgeries to have been stopped for a while, for people not accessing care. And so we've had to look at some of the arrangements we've had and rejigger them a little bit based on the pandemic. But I'd say the other thing, Matthew, that the pandemic has done is it's shown us the value of things that would be perpetuated under value-based care. For example, we have tele-addiction services now, and many people who are struggling from addiction, sadly, more than ever before with the isolation of the pandemic, are just loving the services that are brought by the whole care team into their home. And because of stigma and other reasons, they haven't come in. So a lot of these things that we're learning will actually be more valuable and more readily available in a value-based care model. And if anything, COVID has actually amplified the reason for value-based care, to allow for things like home hospitals and to allow for things like the very appointments for tele-addiction and mental health services that I spoke about. So I think it's accelerating some of the things that you need to do to excel in value-based care. But there's some noise in it right now because of the avoided care. And we just have to work on our arrangements and our agreements with our partners to be able to deal with that part.
Tom, what about from your end? How do you start to look at potentially renegotiating, as Penny talked about, rejiggering some of the contracts you have?
Penny's exactly right. You have to. The level of noise this year is something that no one could have planned for. And so just like the payers, the providers are saying it, so are the payers. And so we know, what your current levels of utilization are. You also know what they were expected to be. And so that's where the relationships and the partnerships come in. Have an open, honest discussion about what's happening and how that impacts the details of the specific arrangement you have. The bottom line is that the value-based care is the future. I think the historical system of reimbursement and paying for healthcare is long since outdated. And I think that moving towards value-based care is incredibly important. And frankly, the pandemic has, to Penny's point, kind of shined a light a little bit on some of the opportunities we have around improving outcomes. And we've talked about telemedicine, and we've talked about the partnerships, and we've talked about some of the things that are, and the innovations that are coming through as a function of this pandemic. So, building all of that in to improving outcomes for individuals, improving health for populations, and lowering costs, I think everyone wins.
And so I'm curious on that front. So if we start to look at maybe 2022, not even 2021 at this point, do you have to start with a whole fresh baseline of metrics because 2020, 2021 have kind of skewed things, or do you just build off of where you are?
from my perspective, you're not starting with a fresh baseline. You're adding some new metrics in. So add some things like the telemedicine visits. You take a look at your utilization and say, okay, we were at this level, now we're down. We need maybe one of the new metrics is getting them back in to see a physician.
Got it. And so lastly, in the less than a minute we have left, Tom, I want to flip to you again. We're moving into open enrollment, over the next couple of months. Talk to me about what that process is going to look like for you guys, especially again with some of the senior population. Most of it, I imagine, is going to be remote. And Penny, if you had any thoughts too, I'd be more than happy to hear those. But Tom, let's start with you.
So it's a really good question. I think the environment for the Medicare Advantage population for the seniors is continually evolving. So every year benefits change, networks change. It's incredibly important for the individuals to evaluate their plan on an annual basis to make sure they're making the right choice for themselves. Historically, they had the opportunity to sit down with an expert and to go through the details of a complex environment and help them navigate that world. This year is going to be different. I think that as an industry, we are adapting. Virtual town halls, online information sessions, access to individuals to answer questions, but it's not the same as sitting down at the kitchen table with the documents in front of them and having that face-to-face conversation. So I think it's the message for me is to make sure that the senior population is evaluating their plan, looking at it on an annual basis and making the right choice for themselves, and take advantage of those online options in the virtual town halls to learn as much as they can.
Sure. And Penny, anything that you're doing with a care team front on that perspective?
Yeah, I'd say, I think that for us, especially with isolation being a big health risk factor, is reaching in to the homes, at least virtually, of those who are struggling, seniors especially, with some of the isolation, for chronic illness management, for support, for home hospital services when they're required. I think it's us being proactively and reaching out when isolation is a big health concern for all of us.
Right. Well, great. We're at the end of our time here. Penny, Tom, thanks so much for taking the time with us today. These are some important topics. We could talk much longer. I think isolation is another topic we could delve into for another half hour or so. But again, thanks for taking time out of your busy schedules to be with us, and stay safe up there.
Thank you, Matthew.
Appreciate it, Matthew. Thank you.
Mm-hmm. And I'm Matthew Weinstock with Modern Healthcare. Be sure to join us next Monday for another edition of The Checkup.